Welcome to today's webinar presented by SAMHSA's Gain Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is part 5 of our virtual learning community on early diversion and is titled Supporting Safety Through 911 and Crisis Line Integration. The presenters today are Debbie Aikens, Jennifer Battle, Kiera Janilla, and Officer Ashley Romo, and I will introduce them shortly. I am Michelle Saunders and will be your moderator for this webinar. I am a consultant with Policy Research Associates and have an extensive background in working in both the private and public sector around the behavioral health and criminal justice field. Before we start our presentations, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or regarding the technology, please type them into the Q&A pod on the right of your screen. We will address as many of your questions to the presenter this time from this. We will also be conducting a poll and appreciate your participation. When you see the poll pop up on your screen, please take a moment and enter your response. This webinar is being recorded and slides will be disseminated via the Gains listserv following this webinar. We will also notify you that when the webinar recording is posted to SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of the webinar. Please note this certificate is for personal portfolio use only and is not for continuing education credit. There is American Sign Language interpretation for this event. The interpreters for today are Jason Farr and Marika Larson. To view American Sign Language interpretation, go to the layout in the upper right-hand corner of the screen and then select side by side for best visibility of the interpreter. There is live captioning for this event. To view live captioning, select the Accept button in the Multimedia pod located in the lower right-hand corner of your WebEx screen. The color contrast of the live caption pod can be changed as needed. The high contrast style is recommended for best visibility. And next, I'd like to introduce today's webinar agenda. Coming up shortly, we are going to hear from Debbie Aikens, Jennifer Battle, Kiera Janilla, and Ashley Romo. And today's presentation is part 5 of the Gain Center's 5-part virtual learning community on early diversion. We will also have a final discussion group coming up in August. So stand by to the Gain Center website and listserv for more information on that. And now I'd like to introduce our speakers for today's presentation. First, we have Debbie Aikens, who is a licensed professional counselor with over 20 years clinical and administrative experience in the behavioral health field. She has a double major in psychology and business from Mississippi State University. She has an MAC from Convent Theological Seminary. She has held numerous positions, including clinical director, director of clinical operations, state director, and regional services administrator. She served as the director of crisis coordination for the Georgia Department of Behavioral Health and Developmental Disabilities since July 2015. This includes implementing national best practice, training for the system and development of and enhancement to the Georgia's crisis and access line, and referral systems as it relates to the crisis system. Debbie serves as the Georgia point of 988 implementation. She's a sought-after national consultant and speaker in the area of crisis services, the role of technology in crisis services and systems, and in using data to drive the crisis services. Welcome, Debbie. Next, I'd like to introduce Jennifer Battle, who is the Director of Access at the Harris Center for Mental Health and Intellectual and Developmental Disabilities in Houston. She oversees the Harris Center Access Hub, which includes the Access Line, the Crisis Line for 39 Texas counties, the regional provider of the National Suicide Prevention Lifeline, soon to be 988, the Southeast Texas Regional Suicide Care Support Center, and the Harris Center Community Outreach Department. In collaboration with the Houston Police Department, Houston Fire Department, and Houston Emergency Communications, Ms. Battle leads the 911 Crisis Call Diversion Program, the first program of its kind in the United States. She also leads the implementation team for the agency's Zero Suicide Initiative and serves as the advisory council member for the Mayor's Challenge to prevent veteran suicide. Ms. Battle serves on the board of the National Association of Crisis Organization Directors, is the co-chair of the National Suicide Prevention Lifeline Screening Committee, serves as a clinical advisory council for the Crisis Text Line and as a Crisis Text Line volunteer, and is a Crisis Center site examiner for the American Association of Suicidology. And we welcome you, Jennifer. Next, we have Kiera Janilla, who is the program manager of the Crisis Call Diversion Program in Houston, Texas. She is a qualified mental health professional with over 6 years of experience in crisis intervention and suicide prevention. Kiera received her Bachelor's of Science degree in psychology from the University of Houston and is in the process of completing her master's degree in clinical mental health counseling from the University of Houston, Victoria. She has training and practice in providing direct care and case management, persons with mental health needs, and program management. She has worked with the Harris Center 24 Crisis Line and Mobile Crisis Team, the Houston Area Women's Center, and the National Crisis Text Line. Kiera joined the Crisis Call Diversion Program in 2019 as the program coordinator, responsible for data and quality review, and was later promoted to program manager, providing general oversight of daily operations. So welcome to it. And we are also joined by Officer Ashley Romo, who is the police officer with the Houston, Texas Police Department Mental Health Division. He's a licensed police officer in the state of Texas. Officer Romo has a Bachelor's of Science in Criminal Justice from Texas State University. So welcome, Officer Romo. And now that we have met our presenters, here are some observations. Here are some observations from the poll that we just had you all take. It's always nice to see after we meet our presenters where our audience is from. And as you can see in the chat box, you can see the results of the poll. It looks like we have about 36% of participants today from an urban area, 20% from suburban, and then about 24% from rural communities. So it's really glad that we've got a nice mixture. And then the fields that are being represented today looks like crisis service providers come in at about 23%, with community-based providers in at 15%, as well as government. And then, it spreads out between corrections, emergency medical, public health, policy. So again, I think we have some judiciary, so, and of course, law enforcement. So it looks like we have a really good mix of folks that is going to be real important for your community when looking at setting up the 988 and crisis line integration. So just before we get started, I'd like to put some context and sort of frame the presentations and the discussion today. In most communities, the first call for mental health crisis is 911. The first responders are police officers. Informed by the work of the National Action Alliance for Suicide Prevention, Crisis Services Task Force, the 2016 Crisis Now publication, and the work of a few communities that had integrated 911 systems of crisis lines, communities have been redesigning crisis response so that mobile crisis teams are the first to respond unless there's a public safety concern. In addition, the FCC regulations and the National Suicide Hotline Designation Act established a mental health three-digit crisis line, known as 988, that will be operational nationally by July of 2022, and states are currently planning for implementation. The American Rescue Plan and enhanced cancer block grant funding made available to states millions of dollars to expand the crisis care continuum so that when the call is for crisis services, there will be resources available to respond and resources available to receive and provide stabilization services. Lastly, community demands to reduce police involvement in crisis response have provided additional momentum for communities to marshal resources to expand crisis resources and to integrate crisis response with law enforcement. So today, our presenters from Harris County and Georgia will describe their groundbreaking efforts to improve crisis response and behavioral health and law enforcement collaboration. These examples can help other communities guide your strategies as you revisit crisis response and prepare for 988 implementation. And at this time, I'd like to now turn it over to Debbie Atkins to begin the presentation. Debbie?
Thank you so much for having me. Welcome, everyone. I hope you're doing well this afternoon. I am Debbie Atkins, and we're going to talk a little bit about Georgia's journey to a system and really looking at a statewide system. So I want to talk a little bit about how our system transformed. It didn't happen overnight. We had a full decade of change, and we'll talk a little bit about those different areas that we implemented and where we are now. Really looking at where we are with 988 and our partnership with 911. And then we'll do a little bit of table setting for what 988 calls for and how that is affecting Georgia. So this is a busy timeline, so I'll just talk you through some of the main points that Georgia went through. Back in 2006, after another crisis, right, we had Hurricane Katrina, Georgia made the decision that we needed a centralized call center. We were an evacuation site, and we had a lot of regional call centers, and when individuals from out of state came, they really did not know who to call to get the services they needed. We made the decision that this was better for the citizens of Georgia, and so we integrated our call line then, and we dubbed it the Georgia Crisis and Access Line. Over time, that has been enhanced, and you'll see over the course of the years what we've done with that. In 2010, Georgia went under a settlement agreement with the Department of Justice. And through that, we increased our community-based services and really looked at crisis very differently. So more ACT teams, our assertive community teams, case management, mobile crisis. Our mobile crisis system was spotty and was run by individual providers versus a statewide system. We made the decision to move to an integrated system in 2012. We rolled out mobile crisis across our entire state. Our live Georgia Crisis and Access line also became a dispatch for all of those teams. We developed an IDD crisis team. We did a lot of lessons learned. We changed our stabilization model from a crisis stabilization standalone to what we call a behavioral health crisis center model. During this time, we also had the Grady pilot come around, and we really want to talk with you a little bit about that and what we learned from that. We had our preferred point of entries. So you can see that my position actually didn't come into being until 2015. So we were run regionally. We didn't have consistency necessarily across all of the state of Georgia. And the department said, okay, it's time. We've grown to the point. So my role is really strategic planning, coordination, and working with program managers within behavioral health divisions, the hospital systems, and our IDD systems to make sure that we're coordinated. We did a really cool thing with a forecasting model with some of the data that we got through our integrated call line and referral system. And it helped us do a lot of forecasting for what our needs are, which has been very valuable as we move into 988. We did some enhancements with text and chat and blended mobile crisis. And then now we're working on really what's it going to look like for 988 and how we're going to build up for that. So these are the three main areas that I'm going to focus on, kind of the call center and what that looks like. The Grady pilot and our partnerships with Grady Hospital, which is one of the larger hospitals in Georgia, and a partnership with our mobile crisis teams to really change how 911 was utilized in Metro Atlanta, and then how we moved forward with sequential intercept mapping. So this is a pictorial graph of what Georgia's crisis system is and what we call a hub model. The Georgia Crisis and Access Line has a lot of functions in Georgia. So they are the call center and the lifeline member for all of Georgians. So even now, if you call the National Suicide Prevention Lifeline, you will get GCAL. It gets routed to us, and they have taken 100% of those calls since 2019. We do mobile crisis dispatch from our GCAL call center. They have a text and chat line, which includes an app on both Apple and other sources. So any phone that you have, you can get the app, you can text, chat, or hit a button, and you can call directly in. This was really targeted for our youth and our millennial population who tend to want to chat versus call. And then we have the crisis bed management system, and this management system has evolved greatly. It was a spreadsheet in a sky to now it is very intuitive, technology advanced, and interacts to let us know supply and demand across the state. You'll see that we have different types of crisis centers. We're still working towards the unified behavioral health crisis center model. We have the possibility of contracting with private psych hospitals for overflow beds when we really need to expand our needs when demand is high. And then we have a few state hospitals left. So we have 4 state hospitals that take adult mental health, and we have a 5th hospital that is completely forensics. So for Grady Hospital actually runs their own 911 center in Metro Atlanta. When they approached to need this pilot, there were a lot of individuals who we're all familiar with that end up in their emergency department. They felt there was a better way. At this point, Georgia was just starting to bid out mobile crisis across the state, and our crisis stabilization units weren't quite to the point they are now, especially having the full crisis system of behavioral health crisis centers where you can walk in and there's police drop-offs. So they really needed to figure out a way to divert individuals from their emergency room because they just didn't have the capacity. So they partnered with one of our mobile crisis responders in Metro Atlanta, which is Behavioral Health Link. And they decided that they were going to go out kind of behind police. So when 911 was called and police were dispatched, the paramedic and the mental health social worker would go out and they would see what they could do to provide information and de-escalation to an individual and try and prevent them from going into the hospitals. And you can see they did a lot of linkage to the community. The licensed clinician was able to really assess them and determine, did they really need to be in a hospital, or could they be diverted in the community? What they found was 60% of the individuals that they went out and saw were diverted from the emergency department. And of those that did need hospitalization, they were able to direct them to one of our crisis stabilization facilities versus sitting in the emergency room. So they found some solutions that they really felt were important and some lessons learned. A lot of it was around the training for EMS. We hear nationally, our response system from 911 is really not trained to be a mental health provider. And what they found was exactly that. An SUV versus an ambulance made a big difference in the moods of individuals they went out and saw. Paramedics changed how they dressed. They didn't show up in an ambulance. They showed up in khakis and a golf shirts. Our clinicians went out in plain clothes. And instead of having the loud radios that you hear, they actually had earpieces. They could communicate and talk without scaring individuals. Law enforcement moved to a transition and supportive role. So they kind of went in, made sure everything was safe and secure, and then they took a step back, and the paramedics and the social workers took over. They didn't need the constraints of ambulances. They could do a health check pretty quickly. The social worker could really work with them, decide what was needed. They gave them hospital access if it was really needed, but it also cut down the time that was needed in the hospital because they were able to give a full mental health assessment and transfer of care. They were able to educate the caregivers who lived in the home. And then they also gave out the Georgia Crisis and Access Line cards. So in future, instead of calling 911, they could call our crisis line directly. So the paramedics were asked kind of, how did this help you? What did you learn? And they learned that they, one, didn't have the expertise to differentiate between mental health diagnoses and determining what was the threat to themselves. They found that they were scared. They had a high level of anxiety when they approached an individual that had mental health concerns. And so they went into direct fault of their training, right? What do? They had a different tone of voice. They took an assertive posture. They wanted law enforcement close by. All of these things escalated individuals who were in crisis. So what they found was that by changing some of these things and having a mental health clinician, they felt safer and more secure. They knew that someone was trained and could interact with an individual, and the situation looked very different. The other things that we learned is we found out creative ways to use the information we had. So before, our emergency response in Metro Atlanta really was the only thing they could do was transport someone to the emergency department. Now, if 911 at Grady gets a call and they feel it is strictly behavioral health, they can transfer to our Georgia Crisis and Access Line. They can send paramedics and do the dual response. There are times paramedics get out and use the Georgia Crisis and Access Line even when the co-responder unit isn't on. They don't run 24/7. So if it's after hours, they'll call the Georgia Crisis Line and see what needs to happen and if they can get mobile crisis to come out. And then what we found at the crisis unit level is that they came with safety plans. They were able to get mental health appointments, transport to a facility when they needed it, and then the emergency department transport with a mental health social worker on board. So when the emergency team went out, they were able to make sure the social worker was there, and everything was much smoother for those that did need a higher level of care. In about 2017, we started in Georgia with the sequential intercept model, which the Pray Foundation, does the training for that. And it started in Metro Atlanta. As you can imagine, Atlanta is very complex. And there are a lot of systems. We have a city system, a county system. It's just a lot. And everyone truly wants to help, but they needed a little more guidance on how to make sure this worked. They did a map, and if y'all have seen sequential intercept maps, it is very detailed. It's actually on their website. But soon after that, we saw, hey, this is something that Georgia needs to be a part of. And DBHTD was approached to be a part of a team that was trained in doing mapping. And so far we've mapped 5 counties out of our 159 because, COVID hit right in the middle of this. But as we've done the mapping, we've really looked at ways that 911 and GCAL can work together. We make sure that invitations include both 911 and GCAL. We have the conversations of the low-hanging fruit and what can we do right now to make things run smoother in that county. As we know, we really wanted to overlay what we have as a state system with our county partners because every community is a little bit different and the resources are a little bit different. We do have co-responder units sprinkled out across Georgia. The Georgia Crisis and Access Line may not know about all of those, but 911 does because they're connected through them. And so we're able to develop programs that meet those county needs. And so far we've mapped rural and urban counties. There are counties that have been mapped in the Savannah area, Metro Atlanta, our Athens area, our college towns, and then some of our more rural counties as well. This will show you kind of our 911 map. There are a lot of 911 call centers in Georgia, and they're independent, just so you know. So as I move into 988, you're going to see some of the struggles that we have in trying to make sure there's a full integration. The partners are great. They want to really integrate well, but they don't dictate what goes on in every single one of these. So every green county, as you can see, has a 911 center. There's only one that doesn't have one, and there are a couple that have the light green actually contract with a neighboring county to run theirs. If you look at all the blue dots in the center, that's Metro Atlanta, and there are city-run PSAPs, so the 911 call centers. That adds for a lot of complexity of how we roll out, how we partner, and how do we make sure there's consistency across the state. So what is our current flow? So if a person's in crisis, they pretty much have to make a decision right now. Am I going to call 911 or am I going to call GCAL? If they call 911, their options are they're going to dispatch law enforcement, fire and rescue, EMS, so our emergency services, or co-responder models. For GCAL, they have the ability to resolve the call. When someone calls, make sure they get access to what they need. They can dispatch a mobile crisis team. They can place someone on our live bed board, or they can direct them to walk into our behavioral health crisis center if there's one in their community. As far as how they relate, GCAL currently has the ability and does every day transfer calls to 911. This would happen in situations where there were weapons, they were doing a live rescue, and they knew that EMS needed to be dispatched. So we've always had the ability for GCAL to reach out to 911. The issue is related that when 911 dispatches, it's usually law enforcement that has to reach back out to GCAL versus actual 911 center. Our goal for 988 is that we will work on a few things that will allow 911 and 988 to be able to communicate a little bit further upstream and will allow us to make sure that calls are directed to the right place. There will still be a need for 911 calls to come through. Our co-responder models will still be dispatched through 911 because those are local and tied to either EMS or law enforcement in that community. And then for 988, we will still have all of the same services, just a little bit more enhanced. And that way we can really communicate better, know what's needed, and how to get the person the right services they need. So our planning with 911 so far, as we look at rolling out 988, and I have to say, Georgia's 911 system is pretty incredible. We have buy-in from our state system, from local counties, from regional authorities, and they're attending our monthly coalition meetings, and they have been incredible in saying, this is what we need to make this work. This is what may not work. So one of the things that we've talked about is training. We really want to have GCAL and 911 operators trained on the same information. They need to understand what the other's going through so that they can better decide if they need to transfer a call. We're in the process of determining what kind of screening documents need to be incorporated into 911, things like our suicide rating scale. And some of this is happening on national levels with CIT, our crisis intervention trainings, and national CIT. They've developed models. So how do we get that out in a state that has 159 different entities that are running 911? We need to talk about assessing the capabilities of both centers. They run very differently. Mental health call center has a little bit more time that they can stay on a call, whereas one of the 911 operators might be the only dispatcher in a county. They need to make a decision within the first 10 to 30 seconds. They need to dispatch who they need to dispatch. And the mentality has always been, you know what, I would rather over dispatch and send police, ambulance, whatever is needed, because the risk is too high if I don't. So we've got to really work through what liabilities look like and all of that as part of the training. And then support mechanisms for 911. They really said once we transfer a call, it's very anxiety provoking to our call centers if they don't have an understanding of what happened. Was it a good call? Was it not? Did we do the right thing? Because they know when they send out an ambulance and the police, they're going to get somewhere. They want to make sure those things are there. So what kind of support do we need to provide to make sure that they feel comfortable transferring to 988? We're going to have to look at guideline changes. So reviewing the risk and liability issues that we've talked about. Establish clear call flows for 911 and 988, which is probably going to be a little bit more time consuming. And we'll be honest, we don't know that we'll be there in July of 22. And then 911 makes those quick decisions. So when do they transfer? When do they not? So these are things that we really want to build in, but it's going to take some time. And then again, the communications feedback loop. Look at quality control. Pull those transfers. Look at them in retrospect. Was this the right call? Learn from it. Review data. Make sure that we're getting better pathways. And we need to meet regularly to make sure that both call center systems feel comfortable with each other and that they trust each other. So these are the things that are in our current plan. So most people know what 988 is, but we'll give you a few details. So 988 is the universal telephone number within the United States for the purposes of national suicide prevention and mental health crisis. So this hotline system is expected to go live in July of 2022. Now, what you will see is that most of our cell phones, if you called it right now, you would still get the National Suicide Prevention Lifeline. There's a lot of things that still have to be worked out, so we really don't want people calling the 988 number just yet, but it is live and capable in most of the cell phone providers. In the law, it actually, and you'll see that the National Suicide Hotline Designation Act is the source here. It allows states to charge fees. It gives a lot of regulations on how that can be done and what they're for. Reports that have to be established and accountability reports. So I'm not going to read you the specifics of the law, but you'll get the handout. Just know that it is not just for the call center. It is appropriate for the routing of calls, for the provision of services and stabilization for anyone who needs that care. There are also two reports that are to go to Congress. Now, the Federal Communications Commission has issued their first response to the feasibility of cost, including automatic dispatch, which is called geolocation. Currently, the National Suicide Prevention Lifeline routes calls based on area codes. And, you know, in Atlanta, as you can imagine, there are a lot of different area codes in Atlanta that aren't from Georgia. We are the melting pot, as people call us. We also have a lot of individuals who started in Atlanta and moved out, right? So if they started in Georgia and they're going to school, say in California, their area code would be in Georgia and we would get that call. We wouldn't have the most resources to help that individual. We would have to connect with the California site. So this is one of the things that we're really waiting on right now. The FCC has put out a report for feedback and comment, and hopefully we will get something back soon giving direction if geolocation will be required and if it's feasible or if they will still move forward with our area code system. SAMHSA has to provide reports that look at what specialized resources are out there for our high-risk population. So our LGBTQ youth, our American Indian and Alaskan Natives, individuals living in rural communities. They have to include recommendations on facilitation of the access to services as well as strategies to implement what's called an integrated voice response, an IVR, to allow the National Suicide Prevention Lifeline callers to access certain specialized services. This would mean that if you called 988, you might get a system of press 1 if you would like someone specialized in LGBTQ youth. The Trevor Project is one of those call centers that might take those calls, and they specialize. So while they're national, they would have a special training to work with individuals. An individual could opt just to go through the regular call system, and they would get the local call center that would know the resources in the community, but that would have access to services there. We are being told that this report is imminent, that we're working on it, and so we're really looking forward to seeing what SAMHSA is going to have for this. So big considerations for every state: someone to talk to. We have to have a plan, whether it's a central call center or a multi-call center, to answer calls in your state. It has to be through a suicide prevention lifeline provider. For Georgia, we already have a central call center, and that is GCAL. And we're in the process of working on additional growth and better ties to 911 as it relates to this someone to talk to. For someone to respond, states have to consider who will respond. When you call 911, you truly expect that either law enforcement, an ambulance, fire and rescue, depending on the type of call, is going to be dispatched. They're going to be there. For 988, we have to decide what that looks like in every community. For Georgia, we do have mobile crisis statewide. We want to better coordinate with 911 and EMS. And then we also want to include more of our outpatient community provider responses. We have ACT teams, as assertive community teams, that really are on call for individuals that they support. We have community service boards, which are our safety net providers. If it's at a time that they can respond to someone who's enrolled in their services, we want to be able to link them, because it's very important if you have a counselor, if you have someone that knows you, that they respond. And then the somewhere to go. We have to consider what stabilization options are there and for capacity building. There are states that have very few of these. There are states that started out with just state hospitals. And you use the emergency room if you're not going to the state hospital. So this is a big part of what we have to look at. It's great to have the calls, but if you don't have somewhere to go to stabilize, they're going to sit either in jails or in emergency rooms. So for Georgia, we do have crisis stabilization units. We have crisis service centers, which are more like urgent care walk-in. We have peer wellness and respite centers that are incredible for diversion from higher levels of care and support in the community. We have detox and substance use treatment inpatient beds, and then our outpatient crisis intervention. And those are for individuals who are already enrolled in services and can access their provider. So opportunities, it's great. We're getting a 3-digit number. It's pathways to allow every person to have the right level of care closest to their home and preventing unnecessary incarceration and for mental health issues. The challenges for Georgia, the interoperability of the 2 distinct systems, 911 and 988, where 988 for us is going to be central for the state and 911 is done through 159 independent sites. Staffing shortage. I cannot say enough about staffing shortages for medical and clinical staff. We could build beautiful buildings with these, but if we can't put people in it to serve individuals, if we can't staff call centers, if we can't staff mobile crisis, we will not be able to meet this challenge. And we have short timelines. You know that this goes live in July of 2022. So what can we get done in this short amount of time? We're committed to the process and we have great partners, and we look forward to seeing how 988 is going to affect Georgia even more. This is my contact information if you have any questions. And I think that we're going to hear from Texas now.
Yeah, thank you, Debbie. And now I'd like to turn things over to Jennifer Battle, Kiera Janella, and Officer Ashley Romo.
Thanks, everyone. Wow, Debbie, that was so great. It's always the best to hear from other states and other centers to kind of hear how people are doing things. And I just really appreciated hearing how Georgia is figuring out these really interesting challenges that we have ahead of us. My name is Jennifer. I'm joined by my colleagues Kiara and Ashley to talk to you a little bit about some of the projects that we have here in our community. So the Harris Center is located in and around the area of Houston, Texas. So those of you that aren't familiar with Harris County, I doubt you would be, but hopefully you're aware of where Houston is. We're a very large community, definitely an urban community, but surrounded by quite a bit of suburban communities. And then through our partnerships with other local mental health authorities, we absolutely serve folks in rural areas as well. We have lots of different programs and services. We serve lots of different folks. So this slide gives you a little bit of an example of some of our projects. Some of you might also be aware of some of our other diversion programs specific to our mental health jail diversion center and some of our other partnerships that we have working to really divert people away from jail, away from hospitals, and toward a more appropriate level of care. So some of those things are here on this timeline. I like this time the same way I love Debbie's timeline, because I think it's really important as we sort of talk about these programs. If you're like me, we go to these workshops and we hear all these cool things that other people are doing, and we're often like, man, I really want to do that. And so I think many of us can do a lot of these things, but it's also important to understand sort of the history and the background of how a lot of these things came to be. So give yourself some space and some grace as you go back to your communities and figure out how to put these pieces in place for you. Our journey toward our 911 crisis call diversion program, actually started way back when there was still a 1 and a 9. Our sort of first big community organizational stakeholder coalition around how do we really partner better with law enforcement, with people with lived experience, with the hospital systems, to really serve people in our community who were experiencing mental health crises. And we know that the best response is not to go to jail. And we know that the best response is not to sit in an emergency room. So at that point in time, all those groups came together and we worked to develop a 24-hour walk-in crisis emergency center. And so that piece really was the place that allowed us to do all these other things that you see on this timeline. And each one of these innovative and interesting and collaborative projects that we did along the way set the precedent for us to continue to move to do more projects because of that trust building, because of that relationship building, because of the amazing outcomes and evaluations that we saw and the impact on the people that we serve and on the community. So fast forward through that timeline, and you'll see in 2015, we actually went live with our 911 crisis call diversion program. But I will tell you, if there were kind of little dots along the timeline, we had conversations about it years before we got to that go live date in 2015. And so it really took some time to really help our partners in our community and ourselves really see the vision around co-locating our behavioral health folks inside of our very large City of Houston PSAP or 911 center. And so you'll also see, Kiara will talk to you a little bit about the addition of not only working with our law enforcement partners, but also adding in our fire department partners along the way for a really comprehensive and strategic initiative to try to help get people the best level of care. And then you'll also hear Kiara talk a little bit about our most recent initiative that's impacting our 911 crisis call diversion project, which is the addition of our mobile rapid response group to the project, which is also very exciting. So one of the reasons that we were able to do all of this work is because we have a very, very well-regarded access hub in our community that is already available to the community 24/7. We take lots of calls. We have really fantastic partnerships in place with many other centers around our state. We are the hub for the National Suicide Prevention Lifeline as well, not only for our county, but for many other counties as well. And we will be one of the regional hubs in our state for 988. The state of Texas absolutely believes in a regional model. You just heard Debbie kind of talk about how Georgia is using a state model. We believe in a regional model because we also really believe that we want to service people as close to their home communities as possible. And so we have 39 local mental health authorities that serve the state of Texas, and there are going to be 4 regional call centers that work collaboratively with all those groups to roll out the 988. And all of those 4 centers are already partners with National Suicide Prevention Lifeline, and we are hoping for a very good and smooth rollout for 988 as we move forward. So, but it was because we have this piece in place that and we were already have been working years and years and years prior to the 911 crisis call diversion project, working with our local law enforcement and EMS around emergency calls. So we had various systems throughout the years where 911 might connect a call to us that was not an imminent risk, or that we were working in real time with some of our crisis intervention response teams through law enforcement or EMS. So being able again to have that comfort and that knowledge about the professionalism and integrity and the training of the people in our call center to basically kind of to pitch this idea of having sort of that call center component lifted out and inserted inside of our 911 system was very, very instrumental in us being able to do this. The other thing that was really important to us moving forward is really the recognition and the understanding of the work that was already happening in our community as that crisis line. Our crisis line is absolutely viewed as part of our diversionary services program. And you'll see this also when Kiara talks about how this is translated inside of 911. The 911 crisis call diversion program has a 50% diversion rate. That means that 50% of the people that they're able to talk to don't need any sort of law enforcement interaction, and the majority of those don't need anybody to go to the scene. So, and it's the same in actually even more than that in our crisis line. In our crisis line, we typically have about an 80% rate of calls that are resolved inside of the crisis line. So although I love the someone to talk to, someone to respond, someone somewhere to go model, keep in mind that for most crisis centers across the United States, there is not an expectation necessarily of needing to send somebody to respond on all those cases, and neither will there be through 988, as we can see pretty obviously through our 911 diversion project. People don't necessarily expect for someone to come out, they expect for some resolution to their case. And so we have our crisis line folks, the folks that the behavioral health specialists are trained to be able to do this level of diversion, which optimizes resources, right? We want to be able to send people out or someone to respond when we need those folks, but we definitely don't have the resources in the community to send somebody to respond on all cases. And I don't think the community wants that. And so being able to empower the person that's calling to be able to see what resources they have is so exciting and exactly the mission of what we're trying to do. And so that's, I think, such a key piece, especially I'm sure there's a lot of folks on this call that are working with your stakeholder groups, your 988 rollout groups in your various states. So please, if you're not working directly with your crisis lines, please do so they can talk to you about all the wonderful diversionary work that they're already doing day to day is to try to, really connect callers to that local care without having to do a law enforcement or emergency services intervention. So the stakeholders that we have specific to this project, our 911 Crisis Call Diversion Project, are my organization, which is the local mental health authority, the Harris Center for Mental Health and IDD, our partners that Ashley Romo is representing through the Houston Police Department, our partners with the Houston Fire Department, and then our overall partner with the City of Houston, which all comes together to form this beautiful thing that we call 911 Crisis Call Diversion. This has been really exciting because it's the true definition of a public-private partnership in our community. And the exciting part about, again, Debbie talking about all of the 911 centers. There's sort of a joke when you talk to 911 folks and they're like, yeah, you've seen one 911 center, you've seen one 911 center. Just like us in the other, in the crisis center community, we all operate a little bit differently. So in the City of Houston, the actual kind of building where our 911 lives is owned by the city. So it's a city building, and the people who initially take the calls are city employees. And then also inside of that exact same building, you have Houston Police Department, Emergency Communication Division staff who are working with dispatch and managing those calls. And then you have the Houston Fire Department dispatch team who's managing those calls. And then inside of this building, which y'all, it looks like it's about the size of a football field. So if you visualize the size of a football field, that's about the same size as the floor of our emergency communication center. Then you have this little spot that's been carved out now for our team from the Harris Center, who is now part of this whole mix, which is fantastic. So I'm going to turn it over to Kiara Harania, who is the program manager over the 911 Crisis Call Diversion Program, to talk to you a little bit about the specifics of how the program actually works.
Thanks, Jennifer. I wanted to talk to you guys about our call flow, the way that we receive our referrals, and some of the work that we do on the calls with our callers. So we can basically receive call referrals from anybody at the Houston Emergency Center. The 911 call takers and HFD call takers have specific training to direct transfer calls directly to a crisis phone counselor at our extension. So we can live assess the caller right there, then and there when they first call 911. We can also receive a callback request from dispatchers, watch command supervisors, the police desk unit, and teleserve to call back on a caller. Once they receive the slip on their board, they can review it and identify a mental health concern, and they'll say, hey, can you check out slip 1234? Maybe there's something on that call that you guys can assist with. And then throughout our shifts, our counselors have their eyes on the board. They're reviewing the computer-aided dispatch system's call queue, and they have specified call codes that they're looking out for that are flagged as a mental health call or a common non-mental health call, but may have a mental health adjacent concern on there that might, require an assessment. they're looking out for those specified call codes and kind of cherry picking them off the board and self-initiating a call back to make contact with the 911 caller. Another cool referral route that we also receive is on the back end. So let's say a patrol officer ends up being dispatched to the call, and whenever they get out there, they're like, well, there's not really any police matter on this call. It's more of a mental health call. They can request their dispatcher retroactively, refer the call to CCD, and then we'll complete an outbound call to make contact with the caller at that point as well. Next slide, please. Okay, so our call takers have triage questions. They have tons of triage questions to better assess the nature of the emergency, but they do have 2 mental health specific triage questions that help identify calls that are eligible for CCD. And these are the 2 questions that they ask. Are you aware or do they appear to have a mental health issue? And is this call in reference to their mental state? And it has to be a yes response to both of those questions in order for the call to be flagged as a mental health or CIT coded call. If it's flagged as a CIT coded call and it's a code 2 and up, it's eligible for CCD to at least make contact and complete an assessment and provide a referral without diverting the call necessarily. We can still assist the caller in that way if we have to send out police. There are a total of 27 mental health call codes with a 911 dispatch, and CCD is authorized to assist on these call codes. I've got our CIT call codes on the left, descriptors, and our non-CIT call codes that may have a mental health component. So for the call codes that are flagged as non-CIT, whenever we review the documentation in the remarks section, we have to make sure that it includes a mental health component for it to be eligible for us to call back on it. Okay, next slide. And here are some triage questions that the HFD call taker will ask. So if somebody calls 911 in Houston and they say, I have a mental health concern, but I want EMS to the hospital, they'll be transferred to an HFD call taker. And that HFD call taker will further triage the call for safety, any crime ongoing, and any medical necessity. So they will ask these additional questions if they're attempting to kill themselves or anybody else, if there's any weapons involved, and then they'll especially ask if they're awake, if there's any bleeding, and if the call is during CCD's operating hours. Currently, our hours are 6 a to 10 p all 7 days of the week, but we are actually in the process of expanding to 24 hours. So pretty soon that won't even be a line item on the triage process because we'll be available all the time. Next slide, please. So here's a kind of like a bird's eye view of CCD's general call flow. So whenever a caller dials 911, the first person that they speak to is the 911 call taker. This is the person that says, Houston 911, do you need medical, police, or fire? And depending on what the caller says, they're either requesting for police, they're requesting for medical or fire, or they're getting a combined response where it entails both agencies, police and fire. If it has a mental health concern and it's a code 2 and up, the call will be referred to CCD, or we're eligible to be picked off the board for the counselor to do an outbound call. And then whenever we make contact with a caller, we'll complete a mental health risk assessment. We follow the crisis intervention model. We employ some de-escalation techniques. We'll do some safety planning, and we'll provide any crisis or outpatient mental health referrals or community referrals as appropriate. However, throughout this whole process, we're not pulling the call off of the board. It's always waiting for police response. In the size of the city that we serve, we do have the opportunity to do that while the call is waiting on the board. So at the end of our assessment, we'll just relay the information that we gathered regarding safety factors to the dispatcher. And then that dispatcher will determine if it's best that the call, if it's okay that the call is diverted, or if it's best that the call is dispatched for emergency response. We might spend, 20, 30 minutes on the call with the caller, whatever the, appropriate time is, depending on the caller's presentation and the risk factors and all that. But whenever we're documenting.
Oh, I think we lost Kiara. So hopefully she'll pop back on. So she was talking about the difference between our dispatch flow and how we document the different calls. So our choices are, of course, diverting the call from full response. And they, again, that part of the solving everything using those de-escalation skills. Our collision-only response, which we'll talk about in a second, that disaster rapid response, MCOT rapid response. And then if emergency response is still needed, of course, they'll be able to send it there. So some of the things, the majority of the skills that are used by the clinical staff, the behavioral health staff at 911 to divert the majority of the calls are our de-escalation techniques, right? Empathetic listening, psychoeducation, talking about coping skills. Oftentimes, especially people calling 911, maybe dealing with a lot of anxiety or panic. We talk a lot about breathing techniques and grounding techniques that we can do right there in the moment with someone, which is really impactful. We spend a lot of time educating and talking about means restriction, which means trying to keep spaces safe in case people are thinking that they could be at risk.
Education that you know, kind of like exploring alternative coping skills or distraction methods. Our focus whenever we're doing safety planning and de-escalation is immediate de-escalation and safety planning. So for some calls that we might get to a point where we talk about, okay, in the future, next time you feel this way, maybe you can do this. But for the majority of our calls, we're thinking about, okay, when I get off the phone with you, you said you like to, you know, listen to that one song that makes you feel good. So maybe you'll spend some time listening to that. And then maybe you'll go watch this one show that you said that you really liked. And then I'll call you back in, you know, 30 to 45 minutes or what have you. Or maybe when you get off the phone, you call mom and ask her to take you to the hospital, whatever the safety plan is. We'll also explore means restriction and increasing the time and distance between the caller and their access to means, especially if they have low intent and they're amenable to safety planning. We do prefer to assess the person in crisis directly. So wherever we're able to, we'll try to do a reach out call directly. Although, you know, respecting that there are nuances to everyone's situation. So if the third party caller that's dialing 911 is not comfortable with us reaching out, then we won't do it. But, you know, they would have to consent and provide us that information for us to be able to do it. We'll also conduct some follow-up calls after the initial contact, depending on the risk level. So if there's a current risk to safety, then we're either staying on the phone with that caller until police or EMS arrive or mobile crisis arrives, if it is that high of a risk, or we're creating a follow-up plan and providing them with concrete next steps for today, or we're following up within the next 1 to 2 to 5 days, 7 days to check in if they were able to access some resources that we provided them. Next slide, please. So very new this year in March, we collaborated with the Mobile Crisis Outreach Team, which is an existing program with the Harris Center. And we brought on, you know, with the Houston Police Department, we were really working to automatically dispatch a mental health only clinician response as an alternative to law enforcement for any calls that are non-violent, non-criminal, non-imminent risk that we're contacting 911 for services. So if we're not able to divert the call over the phone traditionally, which means we don't send out any response at all and we de-escalate and divert the contact over the phone, then we'll try to dispatch mobile crisis to see if we can get that person help on the same day. So since the project launched in March of 2021, we found that upwards of 50% of the calls are resolved on the scene. This means either whenever MCOT came out, they completed an assessment, maybe they safety planned, and they were able to enroll the person in crisis into ongoing services with MCOT, which funnels into our long-term ongoing services that they'll help the person set up. Or maybe they got out there, they assessed, they provided some resources, and the caller said, you know, that's all I really needed. I'm good. I don't really need any additional help. And that's that. Upwards of 30% of the calls were transported to the hospital for safety by the MCOT clinician. We did find that 13% of our calls were still, whenever MCOT was dispatched, they still required additional emergency response. That might be either our MCOT clinician making contact over the phone while they're en route saying, hey, I'm on the way, I'm the one that's responding. And then they found out that something escalated, maybe somebody became violent or did whatever they did. And they had to end up calling 911 and say, hey, we actually need police to come out on this call. Or after MCOT makes it out on the scene and they complete their assessment, they find that the person is not voluntary and ultimately they needed police to assist with the transportation for safety. And we do have some calls where somebody will just walk into a store and say, hey, I'm suicidal. Can you call 911 for me? And they might go sit outside to wait for police, but then we'll dispatch MCOT out to, unknown passerby type of calls like that. And unfortunately, they won't be able to locate the person upon arrival. So 3% of our calls ended up that way. And some eligibility criteria for MCOT rapid response. Truly, there's no age limit for MCOT. They will accept a referral if even if they're younger than 2, but typically the ages that they serve is 3 and up. So the client has to be at least age 3 and up. They have to be currently experiencing a mental health crisis, or there are risk factors for them potentially experiencing a mental health crisis in the future. Or they maybe have mental health needs, but have had significant barriers to accessing mental health services independently. Maybe they don't have transportation. In Harris County, the public transportation typically runs inner city, and then there are some outlier kind of like more urban areas in the county that don't have access to public transportation. And so MCOT is a huge service to those types of areas as well. Client has to be physically located in Harris County and of course able to maintain safety until MCOT arrives. If it's one of those situations need help, within the next maybe like 20 to 30 minutes and we have to stay on the phone with them, most typically we'll end up dispatching law enforcement because they might be able to get there a little bit faster. Those would be the like code 1 or code 2 type of calls. So anything that presents a risk of violence to MCOT staff, or if the caller is currently intoxicated, if they're exhibiting inappropriate sexual behavior, weapons, drug use that they're refusing to secure. Now, we do live in Texas, so a lot of people own guns in general, but it's more like if they are suicidal and their plan is to shoot themselves, but they're not willing to safety plan and put the gun away for MCOT to come out and assess them, then be appropriate. And of course, if there's any criminal matter involved in the call or any medical emergencies, including if it's a suicide in progress, that will require emergency response as well. And I think I'm turning it right back to you, Jennifer.
I'm kind of going back to the sort of program piece, the development pieces. So people always want to know, how do we pay for this? So we initially went to the city to ask for funding, and they said, yeah, cool, sounds like a good idea. But in order for us to fund it, we need to know that it works. And so at the time, there was no one else doing anything like this. So there was no evaluation information from any place that was doing any sort of co-located 911 programming. So we went to the private community and we were able to get some funding through a couple of private foundations. And then we were able to get an innovation grant through the Bureau of Justice Administration. So we were very grateful for that funding because it allowed us to get the program up and running. We were able to show some really fantastic outcomes. And so then we were able to come back to the city of Houston through a matching grant program through the Texas Health and Human Services Community Mental Health Grant, which is our current funding source. So that's who pays the bills for this school project. So I know this is a busy slide, but it has a lot of the kind of outcome stuff that we were talking about to show why the program works. So since the time where we went live in the call center taking calls in 2016, at this point, that this data is a few months old, so we're well over 7,500 or so calls completely diverted away from law enforcement or response, and then over 3,000 calls completely diverted away from fire department or EMS response. And so then under that, you can see, one of the things that we do is track the hours of time saved to our first responders, as well as the cost savings response per call. And so that's very important and impactful whenever you're talking with your communities about that very specific resource savings that you can enact in the community. Obviously, this is also a huge win for the client and for the families because we're able to get them connected to the right level of care And so offering trauma-informed care as well as saving resources. We always say this is why it's such a cool project, because it's win-win-win for everyone. Kiara mentioned earlier some of the other things that we do during the call, which is also listening for and providing a lot of community referrals. You know, one of the things I've always said to Kiara and Ashley was I was so surprised how many people call 911 because they're mad that their kids wouldn't get up and go to school. And so they, you know, an obstinate high schooler that doesn't want to go, you know, then not, you know, we're not going to send police to the scene to convince your kid to get out of bed, but we do want to talk with them because maybe there's something else going on. Is there bullying at the school? Is there like some family situations? So really talking about other types of community resources and supports that could be effective and impactful for that whole family dynamic. This was sort of an unintended outcome, but the ability to actually see if there were people who were already engaged in care and service with our organization, because our staff are there using our electronic medical record in a system separate from the City of Houston 911 call center system. We're able to do real-time connection with their care coordination team to make sure that those clients have their needs met, which was very exciting. Prior to this project, we would not have known if those folks were reaching out for care through a third party. And then, of course, you know, I love a good safety plan. So the ability to talk with people about safety planning for the future. And this is where that education piece comes in too, about the difference between 911 and the other types of services in our community. Moving forward, this will be a primary conversation about helping help people steer towards calling 988 as opposed to 911, and what are the appropriate utilizations of those different programs. This just gives you a brief snapshot of last year. So for 2020, kind of gives you an impact statement. You know, the CCD team talked to over 4,500 folks, completely diverted over 2,000 of those callers away from any sort of emergency dispatch. And then the ability to really tie those numbers in with cost savings to our community. And then once we even took out the cost of the project, the ability to show that the deferment of resources back to the community as a whole was still significant is such a really exciting piece of our ability to really share with our stakeholders the impact that this project is having. You know, our ultimate goal is like, you know, hey, if we can be handling this and pull it off of the dispatch board, then the calls that really need dispatch and need our law enforcement or EMS partners to go out to the scene can get there more quickly. So a couple of nice things that people have said to our team after talking with us. You know, again, people are really surprised that we have this service available and really appreciate the time that we're able to take with them. It's definitely not the expectation that most people have when they call 911 to be able to talk with one of Kiara's amazing phone counselors. And so we really love being able to be there and exceed the community's expectations around what could be possible and provide that education and awareness so they know who else is out there, so that in the future, if they have that need, they can reach out again to us. And so this is our information. And I know Ashley didn't say a whole lot yet. So if you have any questions that are specifically to the role of one of our stakeholders from the police department, I know Ashley will be happy to handle those as we move forward into Q&A.
That may come from a law enforcement perspective, so we want to thank you. We're going to shortly move into the discussion group portion of today's event and have some time to address questions from the audience. If you have not already, please type questions into the Q&A pod to the right of your screen, and we will answer as many as time permits. Again, we want to remind you that there's a webinar attendance certificate. If you're interested in downloading that for personal use, you can do that now. You should have seen a file transfer box pop up on your screen. Under file name, click the file you would like. It should turn blue, and then the download button should turn a darker gray. When you click the download button, it should initiate the process to download the certificate directly to your computer. And if you did not see the file transfer box, you can email Sam Rogers at srogers@prainc.com, And Sam will put his email into the Q&A box for you to have that. So here's some information on an upcoming webinar hosted by Sam's Games Center. On October 25th, there is a webinar on supporting women's reentry, understanding and addressing the needs of women reentering the community. On August 30th, there's a webinar titled Reaching In, Planning for Successful Transition Back into the Community. And on September 2nd, there's a webinar on mitigating behavioral health disparities using culturally relevant approaches to support justice-involved Native American people. Registration information for these webinars will be shared via the Games listserv, so please keep your eye out for that information, and we hope that you can join us. If you haven't signed up for the Games listserv, then I encourage you to sign up. Here's the link. Just enter that link into your favorite web browser, and it will take you to a place to enter your information, and you can make sure you stay up to date with all the Games Center's activities. So thank you again for participating in today's event. If you have any other questions or comments, the Games Center's direct contact is here on this website, and you can go to the SAMHSA Games Center website link, or there's a phone number to directly reach us. If you'd like to stick around for the discussion group on today's webinar, we really encourage you to do so. So thank you, everyone. And now we are going to move into the discussion group. And I'd like to first start by welcoming another participant to join us in the discussion. This is Dr. Michael Hogan, an additional colleague. Dr. Hogan served as the New York State Commissioner of Mental Health from 2007 to 2012, and now operates consulting practice in health and behavioral health care. He served as director of the Ohio Department of Mental Health and commissioner of the Connecticut Department of Mental Health. He chaired the President's New Freedom Commission on Mental Health in 2002 and 2003. Dr. Hogan served as the first behavioral health representative on the board of the Joint Commission and chaired its Standards and Survey Procedures Committee. He has served as a member of the National Action Alliance for Suicide Prevention since it was created in 2010, co-chairing task force on clinical care and intervention and crisis care. He is a member of the National Institute of Mental Health National Mental Health Advisory Council, former president of the National Association of State Mental Health Program Directors, known as NASPID, and is the former board president of NASPID. He's the former board president of NASPID's research initiative from 1989 to 2000. Dr. Hogan's awards for national leadership include recognition by the National Governors Association, the National Alliance on Mental Illness, Campaign for Mental Health Reform, the American College of Mental Health Administration, and the American Psychiatric Association. He is a graduate of Cornell University, earned a master's degree from the State University College in Rockport, New York, and has a PhD from Syracuse University. So we'd like to welcome Dr. Hogan and move into the discussion group with Dr. Hogan joining us. I'd like to let everybody know that Dr. Hogan authored a fact sheet for this webinar titled 911, Law Enforcement, and 988, New Opportunities for Crisis Call Lines and Crisis System Integration, which will be released to all participants of this webinar shortly. But I'd like to start by engaging Dr. Hogan with a question, and then we'll move into questions to include all of our presenters today. So, Dr. Hogan, as you had a chance to listen to today's presentation, I'd like you to provide just a very brief, 2 or 3 minute sort of response reaction to what you heard from 2 communities and their approaches to developing this integration as 988 will be on the horizon next year. Sort of, what did you hear that, really is important for the field to be thinking about, and how you see things moving forward? Because I know timelines are pretty critical here, and some communities may just be starting.
Right. Well, thanks, Michelle. And it's good to be with all of you and appreciate your participation here. You've heard from several of the best examples of this work in the country, and as they've both emphasized, this is hard work that can't be done overnight. But the kind of um, uh, thanks that Jennifer was just sharing from people that have experienced the service on the one hand, and the dollars and cents savings on the other hand, mean that we ought to be exploring these opportunities in many communities. I always have to start by reinforcing the fact that behind these proactive options are current realities that in many states and communities are not so good. The Lifeline, the National Suicide Prevention Lifeline, functions very well, but it's essentially unfunded at the federal level. And the best estimates are there are 5 to 10 times as many mental health calls that come into 911 as go to the place they ought to be going and will be going in a year or so. We also understand that in most communities, law enforcement is the de facto front lines of mental health crisis care. And I've experienced this in my own family with, somebody who was distressed. Police officers came out, they were uber professional and did a great job, but the end result of it was somebody spending several days psychotic in a jail as opposed to in treatment. And often today, if you need a place to go, you go to jail or you go to an emergency department, and both of these are bad places if you're in a mental health crisis. So against that backdrop, and considering the inspiration that we've been offered from Georgia and from Houston, we are nationally kind of having a moment around crisis response right now. Until 2020, there was no national program or policy or guidance on mental health crisis care, and that's now been published by SAMHSA, the Substance Abuse and Mental Health Services Administration. Until now, we've had no national hotline for mental health crises. We've had the lifeline for suicide crises, and with 988, we moved to having what I sometimes think of as 911 for the brain, and which is long overdue. There's been no funding nationally for crisis, for example, the funding for the Lifeline this year is about $20 million nationally. Almost all that goes to, their national functions. Very little goes to crisis centers. And the president's budget for next year is 110 million. And I think that they'll actually be more than that after these reports that Debbie referenced are reviewed at the national level and by the Congress. Starting this year, there was a 5% added to the mental health block grant specifically for crisis services. We think that'll be 10% next year. And in addition, the mental health block grant was tripled for the current year. We may not keep all that money given the pandemic, but it's certainly available for crisis. The American Rescue Plan offers the possibility of 3 years of highly enhanced Medicaid reimbursement for mental health crisis services, which makes them almost free to a state, given that reimbursement rate. And we're seeing movement in lots of states as well, with legislation and with initiatives that begin to follow the path that Georgia and Harris County have laid out. So it's an optimistic time, and it's a good time for you to engage in these partnerships in your communities, recognizing that it's going to be a marathon, not a sprint. And there are, about 200 mental health crisis call centers. There are about 6,000 911 or public safety answer points. And as Jennifer said, you've seen one. So it's going to be a long process, but the potential benefits in terms of honest to God lives saved, people getting care and not just being put in custody are just are profound. So it's a generative time, and I really appreciate the presentations we've had today, and now the opportunity for some conversation. So Michelle, where do you want to lead us?
Yeah, thank you, Dr. Hogan. I think those are some really good insights. So I'm going to start putting some questions out to our various presenters. And there's a lot of good questions that have come in today, so we won't get all of them, unfortunately, but I'm going to try not to sort of jump around too much. But I think the idea around the barriers was an important one, and there were several questions. So I'd like to start with how each of your communities and Dr. Hogan, things you're hearing in the field as far as overcoming some barriers. So one particular question was, what are some solutions that have worked for overcoming some of the technological barriers due to a lack of standardization in coding and the lack of interoperability among the different CAD systems? How can these solutions be scaled up at the state level? And I think there's another question that had to do explaining about the interoperability. And I know, Georgia, I think you mentioned that as well. So maybe I'll start with Georgia, talking about, some of the barriers with getting the systems to work better together or integrate.
I think for us, our biggest issue is that while we have one call center for 988, we have the ability to plug in and have the ability to transfer to all 159 911 centers. The concern comes on the flip side. With 159 911 centers, they all have different levels of technology. Some of them are highly advanced. They are anything from, if you're in that local area, it routes automatically. It allows for text, chat, and different items. And so we do have about 10 centers that are like that. We have also very rudimentary centers that, have just the basics. And so for us to have one system to figure out how to make those connections is difficult. That's part of what our 8-month planning before July of next year. And we're hoping to see, what are some of the low hanging fruits of things that we can do. And then what are, it might mean a backline. The 911 centers can use a backline to get to, instead of calling 988 into our call center, since we have one. But that's going to be a big challenge for us, having that many different centers in Georgia that are very independent and don't have the same technology.
Thank you. Harris County, Jennifer, or?
I apologize. I'm responding to questions in the queue, so I didn't hear the question.
So, so we were talking about the relationship or some of the barriers that occur with the integration, because technologies are different between systems, and sort of how have you all sort of begun to think about or overcome the interoperability between systems and making them talk better together or work better together?
Great question. In specific to the program that we're presenting about today, our 911 crisis call diversion program, this is specific to one center. So we worked all of that interoperability out at the beginning around how all of our internal systems work together. It is part of a conversation. Kiara is very sought after on the national speaking circuit, talking to people from probably like 30 or 40 municipalities and cities just in the last year or so about this particular project. And so one of the things that we're hearing from a lot of cities is because of that technology component, one of the models that other places are starting to use is really working collectively, having their 911 center transfer calls out of the 911 center into the call center. Kind of sounds like maybe what Debbie Shop is doing in Georgia. So that piece, and to me, it's less about the 911 center being able to transfer the call out to the call center and more about, again, that piece around what happens if that call ends up actually, in the rare circumstance, it doesn't happen often, but on the rare circumstance that caller needs to be connected back to dispatch because it needs some sort of response. And so to me, that's where the communication challenge can really happen. But I also believe that that's absolutely not insurmountable. And I'm just going to drop another little tidbit in here, is that one of the things that I'm really interested in, and I have just enough information to be dangerous to drop a sentence but not be able to answer any questions about it, is that all of our 911 systems are called PSAPs, right, which stands for primary something answering point. But there's such a thing as an SSAP, which is a secondary answering point. And so with the next gen 911 systems coming in place, it's possible for crisis centers, I think, to become these SSAPs, which would allow us to be able to have some limited type of access to the computer aided dispatch systems, which I think would really speak to this issue around technology. So that's literally all I know about it. So don't ask me any questions, but you can Google it. And if I find anything else out, then I'll come do a presentation somewhere else on it. Debbie, are y'all looking at that at all? The SSAP model?
We don't have SSAPs across Georgia, but that doesn't mean we're not looking at it. We have developed multiple work groups for 988, and one of them is focused on the call center and 911. And so they're digging deeper into what that would look like. And so we have representation from the Georgia Emergency Communications Authority, which is kind of the state authority. But then we have representation from our local centers to say, yes, this would work, or no, it wouldn't work. I think a lot of our focus right now is, because we know interoperability is going to take a little bit more time. I think a lot of our focus is on triaging the right calls for how that flow will work. And I think that it would be great if we could get something done nationally. You know, the 911 centers all buy technology that helps them do triages. So, you know, if they buy the technology and they click in that this is a medical emergency or a poisoning, it kind of gives them questions to ask. Things are really quick in 911. It has to be. So what would it look like if someone came in for mental health? So instead of us trying to get 159 of those worked out with each of them, it would be great that the technology would come nationally and kind of flow through some of the things that are there. I think the actual calls are going to take us a little bit longer to work out just because of the difference between county to county in Georgia.
Thank you. You know, talking about sort of the relationship between the integrating calls where 911 may, you know, send a call over to the crisis line or back to 911. Somebody was interested to know that when you're integrating these call centers and the exchange of information, what's being put in place to protect people's rights to privacy? And are there issues coming up around, you know, protected health information or things that might be a concern for folks?
I'm happy to start on that one. And then if Kiara or Debbie wants to jump in. So yeah, so the difference between working for us at the 911, we're part of now the 911 system for my team. So it was important for us to understand that anything that's included in a 911 call slip is considered public information. And so the good news is that we're not allowed to put anything in the 911 call slip because we're not credentialed telecommunicator licensed folks. But we've got to make sure that the communications that we have with, well, we would like to make sure that we only provide the information that we feel is necessary to the dispatchers for inclusion potentially on a call slip. Because again, we've come in with our HIPAA mindset, right, around privacy and protection. So these particular calls, if law enforcement is heading out to the scene, then it has that sort of emergency override, which means that, you know, if we need for client safety and for officer safety for the slip to include some specific information, then that's okay. But if it doesn't need to be included, we work hard to make sure that it's not, just again, for our own respect and dignity of the people that we serve, coming kind of from the mental health community side of the house. that accurate, Kiara?
So how that like kind of plays out like for the counselor like on a day to day. I mentioned that we're doing our documentation on separate agency equipment. So it has all the HIPAA encryption, protection, and all that. And we document on the iCarol system, and we might stay on the phone with the caller for a while and get all this information. But whenever we're relaying the information back to the dispatcher, it's about officer safety only. So pertinent risk factors that's related to suicide, violence, and if there's anything like substance use or weapons on the scene, something like that. But then the rest of our assessment information is kept private in a completely separate location. The only places we would share that full assessment is for internal agency referral programs. So such as the Mobile Crisis Rapid Response Program, if we're doing like a homeless outreach team type of referral through our PATH program, those types of referrals. But outside of that, it doesn't leave our system and go into HPDs.
You know, a lot of communities, and as you said, Dr. Hogan, this is not a sprint, it's a marathon, but yet the 988 rollout is just around the corner. So this is sort of all for all three. And Dr. Hogan, I'll start with you and then ask Debbie and Jennifer from their perspective. But as community is beginning this process, if they're not already sort of underway, but you know they're starting these conversations, there's some several questions came up about sort of the collaboration, like who do we get to the table, who sort of starts driving this initiative, you know, how do we reach the key stakeholders, are we making sure we're not leaving someone out? Is there any guidance at the national level to give any sort of roadmap or template down to communities and states and regions to sort of have some idea of who to be bringing to the table and sort of how to educate the community and the stakeholders as to what's needed?
Really good question. There are two resources that I would point people to. The first of those is that there's a website at just crisisnow.com, crisisnow, one word.com, that has got unbelievable resources on it related to things that are going on all around the country. And so one resource is to go there and click around and try to identify, you know, what that you're concerned about or working on, you know, what's somebody else working on in that regard. A second resource is that all the states, or almost all the states right now, are in the middle of a planning grant that's been awarded by Vibrant, which is the company that runs the Suicide Prevention Lifeline nationally. So they've awarded planning grants to all the states, often to the state mental health agency, with some resources that go to the participating call centers in that state. And they're working on developing a preliminary plan right now for 988 rollout. So I think the first draft of those plans is going to be developed in September, and then they're going to be revised over the fall. So the second resource that I would take a look at is what's the planning going on under that planning grant in your state. Now, I don't have off the top of my head, I don't know if Debbie or Jennifer would know how to find out about that, but it's whether there's something at Vibrant or there's something at the state mental health agency, or maybe at the Crisis Now website. Do either of you know?
Don't, but I know that there's a very specific part of that grant that says it has basically like a list, I think, of like who are the recommended people.
Yes.
So I think if you were even to reach out to Vibrant, I don't see why they wouldn't be able to. I mean, it's a public document.
They should at least be able to list the lead agency. Every state's a little bit different. For most, it is the state mental health authority, but a lot of times they've delegated that role to a lead call center. I mean, there are states that have 13, 14 call centers, and they have to decide who's going to be the lead agency. For Georgia, because we own the call center for Georgia, we contract out the service to one of our vendors, but the GCAL is ours, and they are a National Suicide Prevention Lifeline. Georgia is taking control of that through the Department of Behavioral Health and Developmental Disabilities. As far as the types of people that we put in our consortium group, we meet monthly. We made sure that we had our partners. So we put law enforcement. So we looked at both sheriffs and police. We have not only their statewide associations, but we have representatives from across the state in rural and urban. We have the VA on ours because we have a large veteran center and a VA call center in Atlanta. We have all of the national advocates that are Georgia representatives, you know, NAMI, Suicide Prevention, Mental Health America, all of those, as well as our lived experience partners in Georgia. So the Georgia Mental Health Consumer Network, the Georgia Parent Association. So we actually have one for adult and one for kids. We have one for substance use. So we make sure all of those partners, we actually have some of our larger hospitals, one CHOA, which is our children's health care for kids, and Grady, which is a larger adult focused hospital to really weigh in related to that. We put our Office of Planning and Budget on ours. We really wanted the governor's office to hear what we were working on and what we needed to work on. We have our providers of mobile crisis, the call center, our crisis stabilization providers, as well as their association. Ours is pretty robust. We have about 40 different individuals that are on ours. We do it virtually. We use a format where we do kind of a presentation at the beginning about each of the main components, someone to call, somewhere to go, someone to go and somewhere to go. And then we use a mural platform where people can actually put in and they're commenting on weak links, opportunities for 988, so that we're getting the buy-in and the feedback across our system.
Great, thank you, thank you. Within those partnerships, have you all begun to develop, or do you have some MOUs that have been established? Jennifer or Debbie?
Well, yes, for our projects, we have sort of a long-term, we have an MOU with the City of Houston, and we have an MOU with the police department, and then we have an MOU with the fire department. And then they collapsed all those into one. It's called like an interlocal agreement. So which includes the components about confidentiality and privacy. Ours is a little bit complicated because we have so many projects at our organization that engage and involve those particular entities in other ways. So I don't have anything that's like clean and easy. That's like, this is for this particular project. I saw the question in the Q&A, so I don't know what I have would be really helpful. But yes, we do have that in place.
And so for Georgia, because we are the contract holder for both the call center and our mobile crisis systems, there's not really a need for MOUs between any of our crisis providers. What we are trying to work on is, will we need more of a state level MOU for the 911, or will we need MOUs with each individual call center? And that's something that we're working on now to see what that would look like and how to best go about making this something global for all of Georgia.
Okay, thank you. I'd like to and maybe draw Officer Romo in on the conversation, and then, you know, others as you are thinking about this. So, you know, we know there's a strong direction to engage law enforcement less on mental health crisis calls and have more mobile crisis teams, you know, be able to respond. So there's a couple different questions that come up. One is what's sort of the response right now by law enforcement in terms of things like morale or response to the discussion about the engagement of having law enforcement not as involved with mental health calls? I mean, historically they have been who attends to them, and you think that they would, you know, sort of applaud this, but sort of what is some of the response coming out from the law enforcement field in terms of sort of letting go of sort of being that first responder? But I'm interested to hear from law enforcement sort of what some of the discussion or thoughts are around that. And I don't know if is Officer Romo still with us?
Yes, I'm sorry. I was
Oh,
trying to unmute myself. No, I think here at HPD we welcome it. I mean, we've had this whole division, so most of our patrol officers are CIT trained. 75% probably of our whole department is CIT trained, so we're comfortable in doing these calls. But that's only part of our job. So if we have the ability to have mobile, like MPOC going out to these calls where we would have been sent out, we welcome it, and we really think that it's great because at the end of the day, we know that the population or mental health population is better, served by other folks besides us, because we can only do so much to help them at the end of the day with our authority.
And Ashley, one of the things that I think was really interesting for us when we first started this project also was that the police department really saw the role that crisis call diversion could play within officer safety. And so we have a system set up that if a caller is ever talking to us about suicidality and mentions anything about, suicide by cop or anything like that, that we have the ability to now have a system in place to flag that so that the officer can be aware of that going on scene for their own safety and again for the safety of the person on scene, the person at risk. And that was not something that they had in place prior to the partnership with us. And again, was one of these sort of really cool unintended outcomes that we were really excited to help build a policy and a process around. And then Kiara, I know that there's also been from the watch command at the 911 call center, y'all get a lot of really positive feedback from the dispatchers who are really excited for y'all to be there. Do you want to share anything about that?
Yeah, absolutely. So I'm not sure if it was this call or a different call, but we're currently non-essential staffed at CCD, although we're in the process of wanting to change that with our 24-hour expansion. So we do close for trainings and agency holidays, things like that. And the feedback that we always get whenever we do close is like, where were you guys? We wanted you here. So in fact, whenever the freeze happened in Texas in February, and then during Harvey, I wasn't with the program at the time, but I did hear the feedback that during Harvey, when we pulled our staff out, we missed y'all. We wish that you guys were here, and we wanted you guys to take some calls alongside. So it seems the morale and the reception of CCD has been positive. It's been a long time.
Michelle, there's another angle on this that I think I'd like to mention, and that I was thinking of this when Ashley was talking, because CIT has been such an incredible innovation, yet in so many communities, we've kind of forgot that a key element of CIT, as Sam Cochran originally envisioned it, was not just police officers becoming, sort of better trained and capable to respond to these challenges, but a second part of the equation, which was a place that police officers who were qualified by their CIT training and experience to take somebody who could be, dropped off relatively speedily for care instead of custody. And we haven't talked about that third leg of the stool. We've got really three pieces of this crisis stuff that are developing. We talked a lot about the call center component. We've talked a little bit about mobile crisis, but the third level that is very well developed in only a couple places around the country, probably best in Arizona, are crisis receiving facilities that are open 24/7 and medically and nursing staffed, and that have the capability for two things. One is for people in crisis to walk in and maybe get a prescription refill or to see somebody right away. And the second is a sally port out back where an officer can, call ahead, bring somebody up and drop them off for care. And the standard in Arizona is they want this drop off to be done and completed by the officer in less than 10 minutes. And so this third leg of the stool, which Debbie introduced as a place to go, the places to go for somebody in crisis shouldn't be a jail or an ED. Those are not good places for people in crisis, and it's not good for those places to have people in crises who should be getting care somewhere else there. And so a third element that we haven't focused on today, I'll talk about a little bit in that paper you mentioned, and it's another part of the response is crisis receiving facilities.
Thank you, and thank you for raising that, Dr. Hogan, because you're absolutely right. And as we put a lot more emphasis on the crisis response system, it does have an impact on not only the receiving centers, but then the services post crisis to ensure that people are getting connected so they're not going back into crisis. So there really is a lot of pieces that need building and connecting, and I appreciate you sharing that.
And that's one of the more expensive, you know, so the call centers are expensive, mobile is expensive, but when you're talking about receiving facilities that have all the components, think about staffing and how hard it is to find staff right now. And I think that's one of Georgia's concerns. We have that behavioral health crisis center model, which has the three components of a crisis service center, which is urgent care, our temporary observation, which we view kind of like an emergency department. It's quick. You do a much more intensive review, but then someone goes home, and then we have our subacute crisis units attached, and they all have the Sally ports and are designed for drop off, and they're great. But if you can't staff them, then we've got a problem. And there is a national shortage of psychiatrists that want to work in the public sector, of nurses. We can't compete right now with our hospitals that are getting great dollars to give bonuses and incentives for nurses to come work in the med-surg hospitals, and then for social workers. You know, when they can go and work in a private sector versus in the state systems. And so we need incentives. We need to figure out how to fix this issue and then to fund these units. Units in Arizona, which is the kind of gold model, are over $20 million to run one of those facilities because of the amount of nurses and doctors. And then when you're talking about, you know, Georgia's is a little bit scaled down because of just landscape, you know, ours are running $10 to $12 million. That's still a lot of money to operate these, and that's when you have the staff. So it is a challenge for every state to look at moving to that model, even with fees. It's going to be an undertaking because they're not quick to build, you know, year to 18 months to build a system like that and to make sure it's staffed and ready to operate.
Yeah, thank you for adding that. Yeah. And those are things that I think we as all communities, and again, at the national level, really need to be addressing, you know, the investment into the whole continuum of mental health services.
I was also going to say too, like those programs are great too, but they also, there's a whole piece of like the rural community that's very challenging also whenever we try to talk about how many of these type of you know, places to go, where they are, and how easily accessible they are to people that are not in urban and suburban communities is a huge challenge. I know at the beginning of this session, there was like 20-some-odd% of the people in the meeting were from rural communities. So I know you're living this regularly. So these sort of robust type of crisis response systems are challenging to replicate and make equity of care across the entire, you know, population of some of our larger states is a challenge. The other thing I wanted to throw out there too is that, yes, we want to have, you know, the places to go with the Sally ports for law enforcement, but we also want to have places to go before people get to that point. And so, you know, we have a really cool project here in Harris County that's a peer respite center. There's not a whole lot of those around the country, and I think it's a really fantastic model. It's completely run and operated through people who are certified peers, and it's like a house. And if you feel like you're having an emergency and you don't want to be by yourself and you need some supports, you can come to that facility, and it's considered, you know, a hospital diversion program. That's the whole intent of it. And so that we can make those referrals directly through our crisis line. Crisis call diversion can make those referrals. You know, really just trying to do everything we can to prevent people from even needing to do that interaction or with law enforcement or first responders. But you've got to have those tools, right? Like we have to have the sort of full continuum of care available at all different aspects of our community. And it shouldn't be just because you live in a certain zip code or a certain town or a certain state that you get access to something that other people wouldn't. So that's a hard call.
We have 5 of those in the state. We have plans to grow those. And then as we are developing the behavioral health crisis centers, we are incorporating living room models so that urgent care crisis walk-in where anyone can walk in, there's actually a living room model that is peer run, peer led, 24/7 that people can walk into and get that support no matter what. They may never need the higher end services, but they can get that 24 hours a day. And it's been a challenge. Georgia's huge. And so to place those in communities that are rural and urban has been our challenge. We would love to have them all within 50 miles of each other. Right now we have 24. And so we will continue to grow those as we have funding and to put them closer and closer to make sure that we have access in all aspects of Georgia.
And Dr. Hogan, maybe along those lines, as we're getting close to having to wrap up today, I'll ask you, sort of again at the national level, sort of what's the thinking in terms of addressing, particularly when it comes to connectivity and technology in terms of for really remote areas, rural communities, Native American communities on reservations, how's that being engaged? But I think urban areas, not that it's always the easiest, but I think there tends to be more resources and more resources available. But sort of what's the conversation at the national level in terms of some things to think about this and where people might get some other.
Right. Well, it's we've been on a long crawl in the desert when it comes to crisis services. This whole conversation about the opportunities nationally are an oasis. There's just absolutely no doubt, but it's going to be hard. It's going to be hard work, and it's going to take a while. It is quite moving, though. There's something going on in our country now. The mental health responses to COVID have blown people away, especially when it comes to young people who have been out of school and away from their friends. The stuff going on in colleges and universities is unbelievable. And our national leaders are struggling to catch up with this. But when we've seen things like a tripling of the mental health block grant as a part of the rescue plan and the creation of 988 as a single number for the first time, there's hope. It's not going to be an easy path. It's going to be a marathon, not a sprint. But there's hope and opportunity in these times, along with all the bad news that we see every day.
And that's a nice way to end that sort of the idea. Hope springs eternal, and there's hope. And you're right. The pandemic has really impacted a lot, but brought forth a lot of creativity and opportunity. So we hope to see some really good things come out of this. As we wrap for today, unfortunately, we could not get to every question. There was a lot of good questions. I think Jennifer and Debbie and others were trying to answer some in the chat box, so we appreciate that. But you all have, and you'll get a copy of these slides, you'll have their contact information. So we encourage you to reach out as you continue to do your work and have more questions. So we had a great presentation from 2 communities doing wonderful work, having Dr. Hogan with us as a national expert and sort of right in the thick of a lot of this work. We really appreciate your insights and your thoughts you brought. I want to again let you know that Dr. Hogan did author a pretty extensive fact sheet for the community. So when that's ready to be disseminated, it'll get out, and I think it'll give you even some more sort of resources and information to reach for. So again, we want to thank everybody for attending today. We hope to see you at future sessions of the Gain Center's virtual learning community on early diversion. And we wish everybody to be safe and have a good afternoon. So thank you, everyone.